So the first slide here is taken from a publication from Circulation, which shows that atrial fibrillation is growing at an epidemic proportion in, this is taken from United States, but it's, it's growing at an epidemic proportion, which I think it's worldwide. And you can see the growth in men overall and in women. So it's everyone. And this is up to 2000, but when you go and look at it and look at the projected numbers, atrial fibrillation is about 5 to 6 million. And if it keeps growing at the rate it was growing, in 2030, we would have about 10, 11 million people with atrial fibrillation. And by 2050, you would have about 16 million patients with atrial fibrillation. So it's definitely an epidemic that we have to be able to manage as time goes along. And this is true everywhere in the world. This is data from Framingham. And again, this is showing the same kind of thing, that this is a disease mainly of the elderly. As you get older, the prevalence of atrial fibrillation gets much more. This slide shows you different forms of heart rhythm problems that lead to hospitalization. And as you can see, atrial fibrillation alone accounts for 34% of hospitalizations for arrhythmias as a primary cause. So clearly, there is no question that in our field, this is the number one rhythm disorder that we need to be aware of and need to be, targeting.
Nitish, if I can pause you for 1 second. Start. Thank you.
Great. We can start?
Yes.
Okay. So in this slide, what we are trying to show is that atrial fibrillation doesn't exist alone. Atrial fibrillation exists usually in the presence of other heart diseases. The way I tell my patients as well as my trainees is that you have to think of atrial fibrillation like a systemic disease. It's not a localized rhythm disorder that patients have. So this slide shows you that 65% of the patients who have atrial fibrillation have some form of heart disease associated with it, which means could have hypertension, could have obesity, could have diabetes. So atrial fibrillation is associated with that. So in other words, if you are managing a patient with atrial fibrillation, you don't want to just specifically manage atrial fibrillation. You have to look at the patient as a whole. You have to look at managing diabetes, managing obesity, managing hypertension. If you control those things better, then you have a better chance of being able to control atrial fibrillation. Now, 1/3 of the patients do present with what we call lone atrial fibrillation. In other words, in these patients, atrial fibrillation is not associated with heart disease. So these are the patients where if you specifically just target therapy for atrial fibrillation, you can sort of cure it or treat it more successfully. So this slide shows you what are the problems that can be associated with atrial fibrillation. So the number one is obviously symptoms. So the patients will feel their heart beating fast. They'll have symptoms of palpitations. They'll feel discomfort. They have chest discomfort. They can have rapid rates. They can have dizziness. They can, feel like they're going to pass out. Their quality of life is bad. This is the most common presentation. But then there is since this is a disease of the elderly, there are patients who are old who are not aware of that the heart starts beating fast. So these patients will not come complaining of, dizziness or palpitations or things like that. But what can happen is if their heart keeps beating fast, so if their ventricular rate is fast because of atrial fibrillation, they can present with what we call tachycardia-induced cardiomyopathy, which means their heart function goes down. So they start having symptoms of heart failure. Now, it has been shown that atrial fibrillation is associated with increase in cardiac mortality. It is also associated with increase in stroke risk. Now, that is a very important thing that I'm going to address in the next section, which is something that you need to take home from this talk, that significant amount of strokes, especially in the elderly, are associated with atrial fibrillation. So overall, it turns out that it's a big burden to the healthcare system. Burden in the sense of patients presenting with symptoms and coming to the hospital. Burden in the sense of the sequelae of atrial fibrillation, which includes stroke, and managing those patients, managing strokes, managing the quality of life of patients after they have strokes. So that is why we have to, be paid a lot of attention to this disease and how we manage it. Now, if you look at how we classify atrial fibrillation, there are different ways of doing it. And one simple way of classifying it is dividing it into three parts. One is called paroxysmal, one is persistent, and then third one would be permanent. So paroxysmal atrial fibrillation would be patients who go into atrial fibrillation and then it stops by itself. The episodes can last few minutes, few hours, or it can even last a couple of days. But eventually, the patients get out of atrial fibrillation by themselves. Persistent atrial fibrillation is usually atrial fibrillation that comes on and does not go away by itself. And usually it lasts, we call it persistent if it lasts for about a week or so. You usually require electrical cardioversion or pharmacological cardioversion to put these patients back into sinuses. And then finally, the last one would be permanent, where despite attempting cardioversion, these patients stay in atrial fibrillation. So no matter what you try, you cannot get them out of atrial fibrillation. If you look at the duration, the patients who have paroxysmal will have had atrial fibrillation for the least amount of time. As time goes on, patients can go from paroxysmal to persistent to permanent. So the earlier you catch this disease and earlier you try to modify it, the better chances you have of preventing paroxysmal from going into persistent. How do we manage patients with atrial fibrillation? So the management strategy is based on what is shown in these red bars over here. So the number one thing that we have to do, because the ventricle is beating fast, the atrial fibrillation is fast rate in the atrium, which is making the lower chamber of the heart, which is the ventricle, beat very fast. So most of the symptoms are because of that. So you got to give them rate control, which is drugs to slow the ventricular rate. So these would be drugs like AV nodal blockers. The second thing that we would want to do is to try to get them out of atrial fibrillation. So this strategy is called rhythm control strategy. And then the third thing, which I think is the most important thing in atrial fibrillation, is reducing the risk of stroke in these patients. And to do these things, we have different things available. We have simple things like cardioversion, we have antiarrhythmic drugs, we have procedures called catheter ablation, we have drugs that thin the blood to prevent these patients from getting stroke. And then finally, we can put implantable devices in these patients, which can help manage some of these patients with atrial fibrillation.